All right, we will go ahead and get started. So I want to thank you all for joining us here today on Rare Disease Day to talk about finding and treating HoFH. My name's Allison Jamison, and I am going to be your host for today's event, although the main event will be led by Dr. Linda Hemphill, who I'm going to introduce you to shortly. We're excited to have you here. I know I've personally been looking forward to this event for several weeks. And I'm sure that most of you have logged on to hear from Dr. Hemphill, who is an expert with deep knowledge in familial hypercholesterolemia and HoFH. And so you may be wondering, who is Allison and why is she hosting tonight? So I want to take a moment just to introduce myself. I am proud to say that I serve on the board of the Family Heart Foundation. This is a role that I've held for the past 3 years or so. But arguably more importantly, I also have HoFH. So in a way, you could say that I'm an expert in my patient experience. And I think it's really important and telling to note that the Family Heart Foundation is working very hard to cultivate this connected and engaged community for people living with HoFH. And we believe in it so much that we have an individual, myself, living with HoFH, who is serving on the board to represent patient concerns and the patient experience. I was diagnosed with FH when I was 5 years old. I had xanthomas that showed up around age 3. I had a strong family history of heart disease. And when I was 5 and my cholesterol was checked, my total cholesterol was around 850. But even then, it was just diagnosed as FH. It was not until years later, when I was 35, and after I had had 2 separate bypasses, an aortic valve replacement, and a heart attack, that I was actually diagnosed with homozygous FH. And that is really when I found the Family Heart Foundation. And it's been about 11 years now. So a lot of us on this call know living with HoFH, it can be very difficult, and not just physically, but also mentally and emotionally. Living with a rare disease can be isolating. By definition, you're unique. And so finding a community is incredibly important to the patient experience. And prior to finding the Family Heart Foundation, I never met anyone I wasn't related to who had FH or especially HoFH. So I was so grateful to find this community, and it gave me a place where I could meet other people, dozens of families and individuals who were living with HoFH. We could share successes and challenges. We could find support and provide support. And it's really something, it changed my life to find this group. And so it's why I decided to get involved as a patient advocate and why I'm still involved in the board today. So I can personally tell you that the Family Heart Foundation is working actively to continue to build and connect this community so that we can all share experiences with those who understand us. We want HoFH families to know what our options are so that you can get the very best care. And sometimes that information can be hard to find. So it's one of the purposes of our webinar tonight is to bring this information to those who need it and to help you to find it. And so I'm excited to get us started tonight. So let's start with our next slide. And just as a reminder, this is an informational webinar. So if you have questions that are specific to yourself or your family's experience, please talk to your healthcare provider. And if you don't have a healthcare provider who is knowledgeable about HoFH, then the Family Heart Foundation has some resources that you can utilize. And we're going to talk about that again at the end of the session. So let's talk about a few logistics. So again, excited to have you all here tonight. As you'll see in the bottom of your screen, there is a couple of options. One of them says chat, and we would like to invite you all to introduce yourselves tonight. So if you click on that chat button and you pick the option that says panelists and all attendees, drop us a line there. Let us know your name, where you're joining us from. We'd love to see new people joining us as well as seeing those who we know well. So welcome to everybody tonight. And if you pick that, then everybody can see and we can all kind of get to know each other a little bit. So put those in there and you can take a look at who's here. The other function that is available is the Q&A function. And this is where we're going to ask you, as Dr. Hemphill is going through her presentation, if you have questions that you would like her to answer, use that Q&A function to put your questions in there. So at the end of her remarks, I'm going to go through that Q&A and I'm going to ask those questions to her live so that she can answer for everyone to hear. And we're going to try to get to as many as we can. We may be able to text some answers, but we're going to try to get all of those answered through that Q&A today. We would also, at the Family Heart Foundation, like to thank our corporate sponsors, Regeneron and Amrit, as well as our Family Heart family partners, for your support of the HoFH community outreach, education, and support programs. Another thing I'd like to highlight, you'll see in this slide here, in 2020, JAMA Cardiology published an article called Reducing the Clinical and Public Health Burden of Familial Hypercholesterolemia, a Global Call to Action. I think action is the key here. The Family Heart Foundation brought together over 40 organizations, individuals, and experts from around the world, and we worked over the course of 2 years to produce this call of action. So you can see the priorities that we lifted here through that paper, which specifically highlight the need to address homozygous FH and severe FH. And we continue to prioritize HoFH research and education and support. And this webinar, again, is part of that effort. So I hope one takeaway that you'll have for today is that now more than ever, HoFH can be managed. And that is such a success with a rare disease. Hope is not in the future, hope is here. But if we want to be successful in helping more individuals with HoFH live longer and healthier lives, we have to identify those individuals first, whether they're adults or children, and make sure that they have access to all of the available treatments so that we can all reach our treatment goals. And sometimes, and frankly, oftentimes that means that patients and their families are going to have to advocate for themselves. And again, we hope tonight's webinar will help you do that. So with that, I would like to introduce Dr. Linda Hemphill, who's going to lead you through the presentation. Dr. Hemphill is an instructor in medicine at Harvard Medical School and director of the LDL Apheresis unit at the Massachusetts General Hospital. She's an active clinical consultant in lipid management, including high LDL cholesterol, high triglycerides, low HDL cholesterol, combined hyperlipidemia, elevated Lp(a), and metabolic syndrome. She's a fellow of the American Heart Association Council on Arterial Sclerosis, Thrombosis, and Vascular Biology, as well as a fellow of the American College of Cardiology and fellow of the National Lipid Association. She's on the board of the editorial board of the Journal of Clinical Lipidology, and we are thrilled to have her with us here today. So Dr. Hemphill, thank you for joining us, and I will let you take it from here and we'll reconnect with questions.
Thank you, Allison. And I want to join with Allison in welcoming you all and just say that I consider it a privilege to be speaking with you all today. HoFH patients are fighters for their own health and fighters for their families. And increasingly, there is real hope for this condition, and I'll be speaking more to that towards the end of my talk. So next slide. The agenda is to talk about what is homozygous FH and how is it inherited, then finding homozygous FH, and then treatment goals and options for homozygous FH. So first, what is homozygous FH and how is it inherited? I think, most of you, many of you are already familiar with what is and how it is inherited. But just to review, next slide. Homozygous familial hypercholesterolemia is the buildup of LDL cholesterol in the blood anywhere from 4 to 10 times the normal concentration. It is a genetic disorder with 4 known causative genes. And here you see a schematic of LDL cholesterol particles in the bloodstream at the top and a liver cell at the bottom. The liver is responsible for clearing LDL, and the LDL receptor plays the central role. Genetic variants in the LDL receptor are the most common cause of familial hypercholesterolemia. However, a small percentage of patients have genetic variants in ApoB, the protein glue, if you will, on the surface of the LDL particle, which binds it to the receptor. Even less common are mutations in PCSK9 and LDL-RAP1. PCSK9 is a protein which attaches itself to the receptor and eventually leads to its breakdown. Next slide. As you're all very aware, there are 2 forms of familial hypercholesterolemia: Heterozygous FH is more common, 1 in 250 of the general population. In HeFH, a variant or mutated gene is only inherited from one parent. LDL cholesterol is over 190. Onset of coronary disease is generally aged 30 to 60, and most do respond very well to drug therapy. On the other hand, homozygous FH is rare, occurring in 1 in 300,000 people. LDL cholesterol is over 400, and response to drug therapy is poor. Next slide. So LDL cholesterol enters the artery wall, and in a process that starts early in life, forms plaques which gradually build up. The process is silent until clinical manifestations occur: strokes, heart attacks, and blockages in leg arteries. The higher the LDL cholesterol, the younger the onset of disease, if left untreated. If left untreated, those are pivotal words. Next slide. So, years of life and years of healthy life hinge on finding homozygous FH and starting effective treatment as early as possible. Next slide. In 2015, the American Heart Association published criteria for diagnosing both heterozygous and homozygous FH and called for improved detection and early treatment. Homozygous FH should be suspected when LDL is over 400. Many physicians, based on what they were taught in medical school, do not recognize or consider the diagnosis of homozygous FH unless the LDL is over 500. But we now have research from genetic research from South Africa and the Netherlands showing that 25%, over 25% of homozygotes have LDLs under 500. Next slide. This paper was published in 2018 in the Journal of the American College of Cardiology, and it recommends genetic testing in all individuals in whom there is a strong clinical suspicion of FH. Genetic diagnosis of FH in one individual can help with cascade screening of family members and improve detection. Next slide. In fact, we have screening guidelines in the United States since 2011. Screening is recommended at the age of 2 if a family member is diagnosed with FH or has premature heart disease. And it's recommended in all children between 9 and 11, and again at 17 to 21. So we should be in good shape, right? We've known about this since 2011. Well, sadly, this is a study of the Family Heart Foundation's national database of over 300 million individuals in the US. And it says otherwise, almost 3,700 individuals with a total cholesterol over 550 were found who had no diagnosis of FH in their medical record. Although this is both homozygous FH, probably represents both homozygous FH and severe heterozygous FH. Clearly, the message here is anyone with an LDL over 550 or total cholesterol, I guess this is total cholesterol, should have the diagnosis of FH in their chart. And in fact, at that level, should be referred to a specialist in familial hypercholesterolemia. And this map also shows, so these are the blue dots are the individuals that were found, and the red dots are representative of Family Heart Foundation recognized specialists in FH. Next slide. So back to the screening guidelines. It turns out that only approximately 5 to 10% of children between 9 and 11 currently undergo cholesterol screening. So, you know, you're not going to find FH if you don't screen. And how about next slide? How could homozygous FH be missed? Well, the hand xanthomas that you see across the top there would not be missed. However, some physical signs are missed. If you don't examine the Achilles tendons, you're not going to find, you know, Achilles tendon xanthomas. And on the bottom row there of xanthomas, planar xanthomas are often misdiagnosed. And furthermore, furthermore, there are no signs in as many as 45% of patients with homozygous FH. So next slide. Why is early diagnosis and aggressive therapy important in homozygous FH? This paper is on a world registry of homozygous FH, and it reported that it is diagnosed too late and it is undertreated. So sound familiar? The higher the LDL, the greater the risk for cardiovascular events, and the younger the age at which they occur. And the green line on the graph there is individuals in this registry whose untreated LDL was over 660. And you can see that the onset of clinical disease was greater and at younger age than the lower tertiles of LDL cholesterol. However, on the hopeful side, these researchers found that use of 5 lipid-lowering therapies lowered LDL cholesterol by more than 85%, and patients reached acceptable LDL cholesterol levels and consequently better outcomes. So next slide. The Family Heart Foundation is currently preparing a paper on the US CASCADE Registry. It will be the largest longitudinal evaluation of people living with HoFH in the US. There are 16 children and 63 adults. Cholesterol levels at 3 time points will be compared. The untreated LDL, then at enrollment in the registry, and finally the most recent follow-up. So lipid levels based on the number of cholesterol-lowering medications will be reported, as well as the burden of atherosclerotic cardiovascular disease and aortic valve disease. And we want to thank all of you who have consented to be a part of this registry. So moving on to treatment goals and therapies. Next slide. HoFH must be treated aggressively as soon as it is diagnosed, regardless of age. LDL goals are no different than the general population. LDL under 100 for primary prevention and under 70 for someone who has already had a cardiovascular event. Homozygotes may not make it to these levels, but we should not take our eyes off the goal, especially as new therapies become available that can be added to current therapy, which brings us to the third point. Combination therapy, it's at the bottom left-hand side there. Combination therapy is always required in homozygous FH. And the fourth box just refers to the fact that it might be a fight for both you and your physician to get some of these therapies, paperwork, prior authorizations. But as I mentioned earlier, you are all fighters. Next slide. So this is an interesting timeline of the development of cholesterol-lowering therapies, going back to 1973 with the bile acid sequestrants. And in 1987, the first statin came on the market. Lipoprotein apheresis was approved in 1997. And then we have ezetimibe, and I hope you notice that on the right-hand side there is an acceleration of new therapies. Again, pointing to the real hope there is for homozygous FH patients. Lamidipide in 2012, evolocumab and alirocumab, the PCSK9 inhibitors, in 2015, bempedoic acid in 2020, and most recently, evinacumab in February of 21, and inclisiran in December of 21. So these are some of the current therapies, and to start, a brief word about diet. Eat sensibly. Don't put coconut oil in your coffee, but don't obsess on diet. No FH patient is going to get to normal LDL levels with diet alone. So just eat healthy. Statins give 35 to 55% reduction. In LDL, ezetimibe 18 to 25. Bile acid sequestrants, also 18 to 25. The PCSK9 inhibitors, 40 to 65% reduction. So many of you will recognize Repatha and Praluent, but the new kid on the block is Leqvio. I'm not even sure if I'm pronouncing it correctly, which is the previous PCSK9 inhibitors are every 2 week or monthly injections, but Leqvio is a every 6 month injection in your doctor's office. And these, you use one of these. You don't combine PCSK9 inhibitors. You would use one of these. A critical thing to know about, and then there's bempedoic acid 17 to 25, and the combination of bempedoic acid and ezetimibe 38%. Critical thing to know about all these medications, they rely on some measure of LDL receptor activity to work. They improve existing LDL receptor activity and do not work at all in the rare situation called null or receptor negative, where there's nothing to what's called upregulate. Next slide. So these three therapies do not rely on any LDL receptor activity to work. So they provide these robust LDL reductions, even in the patient who has no LDL receptors. So apheresis, 22 to 48% time averaged. I'll give another number a bit later, but I'll explain that with a slide later. Lamidipide, 40 to 50%. and evinacumab, 49% reduction in LDL. Next slide. So starting with a lomidopide, the reason it does not require LDL receptor activity is because it works not by improving the uptake of the LDL particle, which is the small particle at the bottom middle there. Instead, it reduces the synthesis of the precursor of the LDL particle. So the liver secretes the LDL particle, and that is what eventually becomes the LDL particle, and lomidopide inhibits the formation of the VLDL particle. Next slide. So this is the effect of lomidopide. It gives again a 45% reduction in LDL, and maybe we can talk during the Q&A about, but I don't want to focus on it now. The mechanism of the potential side effects and the diet that's necessary to follow when you use lomidopide, but it's very effective, again, in the absence of LDL receptors. Next slide. So evinacumab is an inhibitor of a protein called ANGPTL3, and it is given as a monthly infusion. And the bottom line is, to this complicated slide, that when ANGPTL3 is inhibited, it speeds up the processing of the LDL particle. I don't have a pointer, but the VLDL particle is, in the center there, which again is secreted by the liver, and ANGPTL3 speeds up the processing of that VLDL particle into smaller particles that are then preferentially taken up not by the LDL receptor, but by a what's called the scavenger receptor. And homozygous FH patients have scavenger receptors. So it's a receptor that's not used ordinarily all that much in lipid metabolism. But when you inhibit ANGPTL3, you speed up this processing of the VLDL particle such that it's taken up by the scavenger receptor. This, I want to say, this is also important with regard to evinacumab. It is approved for children 12 and up, and it will likely be approved shortly for children aged 5 to 11. Next slide. So evinacumab lowers LDL 50% in homozygous FH patients who have no receptor activity. That's the light green line, equal to the reduction seen in patients with LDL receptor activity, and that's the dark green line. So very effective for all HoFH patients. Next slide. So back to LDL apheresis, the percent reduction, if you consider the initial reduction after apheresis is instituted, the graph here is showing the what's called the pre and the post LDLs. So over 1 to 2 weeks, the LDL bounces back up to baseline. But when you first initiate it, it does not bounce all the way back to baseline until it reaches a new baseline. So overall, the time average reduction with LDL apheresis is more like 50%. And finally, we have several of our Family Heart Foundation heroes undergoing apheresis here. And that concludes, key takeaways. Early and aggressive LDL lowering with combination therapy reduces the risk of homozygous FH. The diagnosis should be considered with an LDL of 400 or above, not that old number of 500. And it is important, if you have homozygous FH, to have a lipid specialist. I mean, many heterozygotes, and sort of in the lower range, not the severe heterozygotes, can be managed by their primary cares, but certainly all homozygous FH patients should have a lipid specialist who will work to get them those advanced therapies and the combination therapies that will get them as close to those goals as possible. So, Q&A.
All right, thank you, Dr. Hemphill. So we've gotten several questions as we've gone, and if you continue to have them, feel free to enter them and I will read them as well. So our first question is, what is the impact of these medications, especially if you've already had a heart attack, and how does it impact the health of your liver if you're taking multiple medications? So this person is asking sort of what are the side effects of the medications generally, but also specifically if you already have coronary disease.
Well, if you already have coronary disease, then you want to work even harder on getting the LDL as low as possible. And these really the only medication that has concern for the liver is lamidopide. And that is a medication where you have to, get frequent liver function tests. That being said, in my own experience, I have 3 patients on lamidopide, 3 homozygotes on lamidopide, and they have not had problems with their liver function tests. But that's really the only statins. You always hear about statins in the liver. The FDA dropped any requirement to monitor liver enzymes in patients on statin therapy. There hasn't been any liver problem with the newer medications, the monoclonals. Inclisiran is what's called a small interfering RNA. No problem with liver. So I would say that if somebody already has coronary disease, even more, they should be having combination therapy with these medications.
Sounds like the risk of not treating is much greater than the risks you face with the treatments.
Yeah.
There are a couple of questions related to children, and you talked about pediatric screening. So one question here is, do you have information on testing infants? Is that something that you should consider? And if so, what level of LDL in an infant would be a concern?
Typically the screening is done at age 2 because no therapy is done under the age of 2. But the LDL is the same. The diagnostic for homozygous FH 400.
Okay. I think I've heard as well that in infants, maybe cholesterol is naturally higher, but you're saying that same sort of threshold applies regardless of age of the child.
Yes, yeah.
Okay, great. Then there was a question related again to the testing of children, and are insurance companies aware of this necessity to screen, and would they cover the labs for a 2-year-old who is getting a cholesterol screening?
Hmm.
May vary
Uh,
by insurance company, maybe.
yeah, I don't treat kids, and I can't imagine that insurance would not pay for a simple lab test when you have a family history
Mhm.
of either, premature coronary disease or FH.
Mhm.
So,
Because at this point, we are talking about a simple lab test and not a genetic test or something like that. So it's not a terribly expensive test to begin with, I would imagine.
right, right.
Yeah. Yeah. So I think that does tie in very much with sort of the message of needing to be your own advocate, that if your pediatrician's not suggesting it and you have the family history, it might be a conversation to have with your pediatrician. Which actually leads us to the next question of knowing that FH is underdiagnosed, then how much education do you see that medical students are getting and as they're being trained about FH or HoFH?
Well, at least at Harvard, there's good news there, where you have teaching which is up to date in terms of when to think about homozygous FH, and I know that honestly there's more of a focus on it than when I was in medical school. So yeah, I think the younger docs coming out of medical school are going to be more aware.
Mhm. So it sounds like we have a potential future medical student here asking questions, but says, I've never heard of the scavenger receptor that you mentioned with the evinacumab. So is that something that everyone has? Is it something that's unique to FH patients, or can you talk more about the role of the scavenger receptor?
So everyone has it. Its role is to pick up what's called the intermediate density lipoproteins or remnant, and so it's not that homozygous patients have them and other people don't. And I didn't mean to imply that. It's everyone has scavenger receptors, but they don't get as much action as they get when you inhibit this protein ANGPTL3, which literally sort of directs the VLDL into the IDL quicker, so that it's taken up there instead of making its way around through LDL, where it would be taken up by the LDL receptor.
Okay, so here's one sort of related to once you've decided to pursue treatment. So an attendee who has an 8-year-old who has elevated LDL and is going to start therapy, but their genetic test came back as negative, which I think can happen because we don't know every mutation, but I'll let you address that. But the bottom line question is, if you can get that lower in someone starting at age of 8, what happens to the mortality rate or the expected longevity of that patient if you're able to get it down early in life? Does it go back to a general population life expectancy?
So I took out the what I call the trajectory slide, and I took it out because it was only showing benefit in heterozygotes. So trajectory, the higher the LDL, the longer it's high, the younger you're going to have manifestations of atherosclerotic cardiovascular disease. And so, this lovely trajectory slide showed the heterozygotes, kind of, if you start the statin at 18, the trajectory is like this. If you start it at 8, it's starting to look like the general population. Unfortunately, somebody needs to redo that slide because it had the homozygotes just, that's it. We know that's not true. That we can bend the curve for homozygous FH as well. Yeah.
Great. That's excellent news. Like we said, the hope is now in all of the new developments that we have coming up. There is another question related to these new developments. So I don't know if you're familiar with this, but are there any new developments in gene editing to treat HoFH?
So that's very interesting. Initially the idea was that, well, we'll put in the LDL receptor gene for somebody who's missing it. We'll insert the LDL receptor gene. It turns out it's a lot harder to insert than it is to what they call knock out. And so we have this medication, evinacumab, which inhibits ANGPTL3 and lowers LDL 50% even in people who don't have any LDL receptors. So actually, what is being worked on is knocking out the ANGPTL3 gene. Mm-hmm. And so it's they call it one and done. Mm-hmm. You have the infusion and you're done.
So like not doing them monthly anymore. Yeah. Okay. Yeah. That's interesting. And I think particularly with HoFH, I am seeing several questions related to children. And so I think we have some parents here. And this is a question I've seen in our online communities. Are there any side effects or particular concerns about children in prepubescent taking statin therapy or any of the other therapies? Is there any concern there for very young children?
So actually younger than 8. So no problem with puberty. That's been looked at in multiple studies with multiple statins, starting at age 8. Mm-hmm. So, and no problem with growth and development. So, and statins obviously are used in homozygotes much younger than age 8. In terms of a FDA approved indication and studies having been done, no, studies haven't been done, but the fact that there's no problem with growth and development in 8-year-olds and up, I think you can infer that there wouldn't be any problem with growth and development in younger kids with the statins.
Mm-hmm. And would you say in general that sort of the earliest treatment is going, particular in the case of HoFH, is going to be the most beneficial for the child?
Yes. Yeah.
And here's a question that, like, gosh, what a blessing that we get to ask it. With the advances that we've had, is there a level of LDL that is too low?
No. You can't have too much money in the bank and you can't have an LDL too low.
As I think a lot of people have seen some really impressively low numbers, and that it's almost a, gosh, is this too low? Do I need this? Do I need more of it in my system? And so you say no. No low is too low.
So we've got a lot of data on that from actually genetics. One of the causes of FH is a gain of function in PCSK9. There are people who have loss of function in that gene, so they have much lower levels of PCSK9, and homozygote loss of function have no PCSK9, and their LDLs are 5, and they're fine, you know.
Wow.
So yeah, and
So,
they never get coronary disease.
yeah, it's a wonderful problem to have, right?
Yeah, yeah.
And so related to that, then I think this was in one of your slides, but we've got a lot of data. But what is sort of a goal level or a good level of LDL for a patient who has coronary artery disease?
Well, you know, you hear under 70, and that basically comes from the clinical trials. There's really nothing magic about 70. And in fact, we know if you can get lower, get lower. Yeah.
We also have a couple people tonight, and I know sometimes high LP little a and high LDL go together, and sometimes they don't. But we have a couple folks on tonight who might have both. So, of the treatments that we've talked about here, are there ones that are also applicable to those with high LP little a, or ones that might be in the work for that audience as well?
So the PCSK9 inhibitors lower LPA about 25%. And you know, there is a medication in development for lowering LPA. And it's very, very effective. It lowers LPA 80%. But it probably won't be in the market for another 3 or so years. It's currently in a what's called a cardiovascular outcomes trial. So people who have heart attacks, strokes, peripheral vascular disease, and high LPA, it's called the Horizon trial. They're randomized to this new medication called pelacarsen versus placebo, and it's probably going to take another 3 years to get the results of that, at which point and I think it's going to be a positive trial. And at that point, I'm hopeful that it'll be on the market.
In looking at the different treatment options that we've talked about tonight, is there a preferred order of adding these to your treatment plan?
You know, I think people typically start with the statins, you know, and after that, you know, the PCSK9 inhibitors. I like to go for the ones that give the big bang, you know, for the buck with the least side effects. Lamidopide is very effective, and I'm really grateful for my patients who are having good results with that. And but you know, I would put it further down the line because of the potential GI side effects and the need to monitor the liver. But it definitely, again, especially for these folks who are receptor negative. Yeah.
And is there, if statins are sort of the general first line of defense, is there a particular statin that is recommended for children? Is there, you know, there, I think different levels of intensity of the statins are the ones that you typically start children with?
So in homozygotes, you know, now I don't treat children, so maybe somebody else can correct me, but I would use the high intensity because you're dealing with homozygous FH.
And the high intensity ones include
just
one?
Torvastatin and rosuvastatin.
Okay.
Those are the only high intensity. Yeah.
Okay. And then we have a question asking if you can address, and I don't have more details, so hopefully you'll understand the question, addressing oxidation and LDL plaque.
You know, there have been attempts to reduce atherosclerosis with other therapies besides LDL lowering therapies, anti-inflammatory. They haven't panned out. I think really it's about the LDL.
Mm-hmm.
Yeah.
Okay. And I think we also have one last question about LPA, Lp(a). If you know sort of the ranges that should be the target for an Lp(a) target.
So the relationship of LPA to cardiovascular disease was felt to be curvilinear. What they say, there's some takeoff point, but it really is a linear relationship. However, in terms of having a significant, well, I'll back up. It's important to know that the definition of normal is just sort of a lab definition. So when you talk about 75 nanomoles per liter or 30 milligrams per deciliter being normal, that's simply a lab definition. What we really want to know is the relationship to atherosclerotic cardiovascular disease, the epidemiology. And so when you get to about 125 on the nanomole per liter measure, or 50 on the milligram per deciliter measure, it's starting to have a significant impact on risk. But again, currently, apart from a mild reduction with the PCSK9 inhibitors, there isn't a lot you can do.
Right.
So stay tuned.
Stay tuned. Yeah, sounds like there's more coming down the pike there. I think we have about 6 minutes left or so. So we have a few slides that we would like to end with. I think we have a question here regarding if we can help find a lipid specialist. So I would like to talk a little bit about some of the resources that the Family Heart Foundation has available. So we'll take a look here. Actually, the first one addresses that question that was there. If you don't have a specialist that you're working with now for FH, the website, the Family Heart website, does have a care navigation center, and here you can go in and enter your location and find a specialist near you. Gives lots of great information, contact information. So if you need to find someone, you can use this resource. If you still aren't able to find someone, then you can reach out to the Family Heart Foundation directly, and we're happy to help you locate someone nearby. And something we do all the time, so happy to do that. Don't be afraid to ask. I would encourage everybody who's interested, has a family member impacted, a patient impacted, a work colleague, whoever that you know that might be living with HoFH, encourage them to join this community. Like I said, it was the first time in my life that I had met other people who were like me, and it's just such a tremendous relief and resource to be able to connect. So we have a Facebook group, we have newsletters, we have events, in person and virtually, and just a lot of resources that are available. So I would encourage you to get involved with this community. We also have resources that you can pull off of the website. I think it shows it on the next slide, that explain HoFH. If you need to have a conversation with a family member or with a healthcare provider, there are tons of materials available again on the website that you can share with whoever in your life might need to know. So you can find those on the Family Heart website as well. So there's a ton there for you to see. We also have participated in continuing medical education. So these courses are free. They're available to healthcare providers and to the general public. So much like tonight, to get access to what is coming, what is known, expert advice and opinion, those are great things that the Family Heart Foundation can offer as well. So it's a tremendous resource. Encourage you to visit that website and see what we have. And I think, I would like to thank Dr. Hemphill again for your time, for this incredible information that you've shared with us, and everybody for coming tonight and joining us from wherever you are in the world and asking your questions. I hope we got to all of them. But if we did not, again, you can reach out to the foundation and ask us, and we're happy to help. And we will have a recording available of tonight's session about 2 weeks after today that will be available on the website. So thank you, Dr. Hemphill, and thank you everyone for joining us.